evening, ladies and gentlemen, and a special warm welcome to our specially invited guests and colleagues from the Mona and Keyville campuses. I am Anne-Marie Minghorn, founding executive director of the Pathology Club of UE and chair of this evening's event. I would like to thank you for joining us for our 22nd installment of CPALMSI. At this time, ladies and gentlemen, I am privileged to be introducing the speaker for this evening, Dr. Nour Yadak, who will be sharing her wealth of experience and passion for pathology in a short overview of transplant pathology. But before we begin, I will give a brief background about Dr. Yadak and an insight into the noble contribution she has made to transplant pathology research and developments in the field. Dr. Nour Yadak is an assistant professor at the Department of Pathology, University of Tennessee Health Science Center. She also serves as a GI liver pathologist at University Clinical Health in Memphis, Tennessee. Dr. Yadak was born in Amman, Jordan, and received her medical degree from Jordan University of Science and Technology. She then completed pathology residency at University of Tennessee Health Science Center, a surgical pathology fellowship at the University of New Mexico, and a liver and transplant pathology fellowship at the University of Pittsburgh Medical Center. Dr. Yadak's research includes a pilot study of ex vivo MRI-PDFF of donor livers for assessment of steatosis and predicting early graft dysfunction, among many others, and she continues to contribute to various research in the field of transplant, GI, and liver pathology. Dr. Yadak's professional experience spans over a decade, and her contributions to the field of pathology are highly valued. Her interests in pathology include gastrointestinal and liver pathology, transplant pathology, and medical education. She's committed to providing quality education to her students and is highly regarded by her peers for her excellent teaching skills. Without a doubt, Dr. Nour Yadak is a motivating figure for us in the MBBS program, aspiring pathologists, and those interested in the field of transplant pathology. An inspiration to many, we are all honored, pleased, and privileged for her to be here with us this evening. And so, ladies and gentlemen, I ask where you are to welcome the very knowledgeable and most certainly the very passionate Dr. Nour Yadak. Over to you, Dr. Yadak.
Thank you so much, Anne-Marie, for this nice introduction. Thanks a lot, and thanks for inviting me today. It's my pleasure, actually, to give you a little bit of talk about what we do as a transplant pathology. So let's start. Okay, so I think everybody will be able to see my screen. Okay. So yes, today I'll try to speak a little bit about the transplant pathology and what we do in the transplant field in general. First of all, I want to give you some reference. A few of my pictures in this lectures are coming from the AJKD Atlas of Renal Pathology, from Pathology Outline, and from the place where I did my fellowship trained, UPMC, the Transplant Pathology website. So the question that's come in mind is for the medical student who decide to pursue a pathology as their career, they went to the pathology residency, and after that, they're going to decide to do a fellowship. The question that's going to come to mind is, are you willing or are you going to be a transplant pathologist? In order to answer this question, let's see what we do in the transplant pathology field. And based on that, you can decide if you want to be or not. First, I want you to understand. So just a little bit to talk about the transplant world in general, and then we can specify it to the transplant pathology. So in transplant, when we get the solid organ transplant and the stem cell transplant, this has become as a miracle in medicine happening in the 20th century. Transplants save a lot of people's lives. You can change dramatically the people even lifestyle. So you can imagine you have a person with a kidney transplant. Before that, they were in kidney dialysis maybe 1 or 2 times per week. They were sick all the time, fatigue all the time. They cannot do their normal function in their normal life. So they cannot even practicing their job correctly, and they cannot do anything. So you can see the dramatic change once we have the transplant kidney for them. It's completely changing their life. So this is really a precious organs for them. And this is a very important field that came in the 20th century. The transplant is not rely on one person. So you need a transplant team to make this organ as effective, as functional as you can. Start with the patient, of course. You need the surgeon. you need the anesthesiologist, the nurse, the person who coordinates the organ procurement, the donation, the recipients for these organs. You need a pathologist, you need a social worker. So it's a transplant team that lead to this successful transplant procedure. This slide is just to provide you an idea what is the waiting list for the patients who needs organs. This statistic came from 2021. So if you can see the kidney, more than 90,000 of people are waiting for kidney. Comparison in how many we transplant, it's almost 25,000 kidneys. So you can see we have this gap. So unfortunately, kidney is one of the organs that will have a long waiting list for these people. Usually the patient will be 4 to 7 years sometimes in order to get one kidney. Compared to the liver, heart, lung, others, so we transplant skin, cornea, there's a different other thing we can do. Pancreas, small bowel, different organs now it's been in the field in the era of the transplant. This data from UNOS to show you, this is just recently in 2022. UNOS, it's a federal, it's like a network or it's an organization. It's a United National Network for Organ Sharing. So this is a work under the federal law in order to organize the organ procurement and the recipient in the USA. So transplant is not like you come here in Tennessee and you say like, okay, this patient needs a kidney transplant. It's okay, come and you can get it. It's a little bit more complicated procedure to put the patient in the waiting list, wait to the suitable organ to come, and then get that organ ready for that patient. So you can see in 2022, we had more than 40,000 life-saving organ transplant happening. And compared to how many donors we have from disease and living donor, we have more than 20,000 donors. So you can see the number differences. That is because especially the disease donor represent for you multiple organs. So they can donate heart, lung, kidney, small bowel, pancreas. So you can see multiple organs for each donor. The good thing now, we start to accept also living donor. In the past, they do for kidney. Now we start for many things like liver, for example. And this has helped a little bit to decrease the gap that I show you in the first slide about between the donor and the recipient. So hopefully we can decrease the waiting list. Giving this and put this in mind for what I'm giving you this statistic data, you can see that each organ is really a precious organ for the person who needs that organ. That means the whole transplant team, they try very hardly to make this organ function and effective without failure in that recipient, because it's not easy to get another organ. So we all try our best to get the best function for that organ. And that's here come as a role of pathologist to help the clinician to identify where this organ is not working properly. So they need to increase the immunosuppression or do their own treatment modality so we can save this organ. Because of that, we have Transplant Pathology Fellowship. So let's have an idea what we do in the transplant pathology. So transplant pathology, as you know, in pathology, we have an AP specialty and we have a CP specialty. It's considered from AP specialty, anatomic pathology subspecialty. In this fellowship, you can have either 1 or 2 year fellowship. It depends on the institution and it depends on you too. So if you want to have more research, depth in the research and other this stuff, you can have it for 2 years. But most of the time, most of the places will offer 1 year fellowship. So you can imagine for how many organs we have, and it's not easy to have a transplant institution in every state in America. That means it's a few places that offer this fellowship. So it's not like a common fellowship. You see it around that in the USA for any way. There's a few places, and these places can offer for not just a transplant by itself. Some places will offer for it additional liver fellowship. So you have it like the one I did in UPMC, it's liver and transplant pathology fellowship. Some other places will provide medical kidney and a transplant, and some places will provide combined medical kidney, medical liver, as well as the transplant pathology, you do it in one time. Because you will see there's so much overlapping, especially in kidney and liver, between the medical kidney disease and the transplant kidney. Because of this overlapping, sometimes it's good to do the fellowship as a combination to see the medical liver and kidney that relate, or medical kidney, in addition to the kidney and liver transplant at the same time. Okay. Based on that, let's see. You decide you're going to be transplant pathologist, you go to the transplant pathology fellowship. What type of a specimen we received? Kidney. I will start with kidney because this is one of the common organ, right? And most demanding organ for the waiting list, or whether from the patients. It's a common organ that we receive it as in the transplant pathology department. When we receive kidney, we receive the native kidney. What I mean with the native, that means that's the kidney that's still in the recipient, the patient's own kidney. We can get biopsy and we can get explant. We get donor kidney biopsy, and we get also allograft kidney biopsy. Allograft means that's the kidney that's been transplanted in the patient body. So let's talk a little bit in depth about each type of the biopsy and what we do in that field as a fellowship trained transplant pathology. Let's start with the native kidney. So one of the common specimen that we get is a native kidney biopsy. We can get the biopsy, or we can get which biopsy for native kidney. The main reason the clinician wants you to get this kidney is to evaluate for the medical kidney disease problem that this patient. Is it the patient has primary kidney disease? Does it have a secondary kidney disease? Remember from your medical school, the primary one, what I'm talking about, the glomerulonephritis type. Remember the membranous glomerular focal segmental glomerulosclerosis. We have a minimal change disease and all these other type for primary kidney disease. In addition, we have secondary kidney disease. Sometimes the kidney will be affected secondary to a systemic process that's happening in the body, diabetes, hypertension, patient with systemic amyloidosis. They can have problem that can affect in the progression of the disease, the kidney too. So the clinician want to make sure what is the status for this kidney. So they biopsy that kidney and ask the pathologist to evaluate it. Other reason we also get the kidney biopsy for staging for certain disease. One of the common thing is for connective tissue disease, SLE, systemic lupus erythematosus. So they will give you the biopsy, especially if this patient have abnormal kidney function test. So the clinician wanted from you to know, ask the pathologist, okay, how bad the kidney is affected by this disease. And we have a staging that we go through for lupus-related nephritis. We give the clinician that, and sometimes the patient will end up with end-stage kidney disease, and then they need to be in the transplant list. So you can see multiple medical kidney problems can happen. And the unique thing of kidney is you don't rely only on H&E slide. So you don't rely on a single biopsy to see it in the pink and blue slide that we see in the pathology. Kidney usually need pink and blue slide, like this one, which we call it H&E slide, but also we need another core biopsy for immunofluorescence and another one for electron microscope. Especially for primary kidney disease, remember, it's a different immune complex deposition give you a different pattern, and this different pattern give you a different primary disease. Membranous glomerulonephritis will have a different deposition, whether it is IgG or it is IgA, or it's a granular, it is linear. So all of these details is very important and essential in diagnosis medical kidney disease. In addition, we get electron microscope. Is it subepithelial deposit? Is it subendothelial deposit? Is it within the basement membrane? All of these different patterns give you a different disease. So for example, the case I'm showing to you here, it is membranous glomerulonephritis. So you can see we have thickening of the basement membrane in the glomeruli. Then we have a granular deposition of the IgG and the subepithelial deposit under the electron microscope. This fit for membranous glomerulonephritis. The picture here shows you secondary process happening to this kidney. It's called nodular sclerosis. This, for example, is secondary to diabetes. So this patient has diabetic nephropathy that's affecting his kidney. So this is important because what's happening is, especially with these patients have end-stage kidney disease, the clinician want to make sure what is really the main disease that's affecting the kidney. It's going to affect their decision to put the patient on the transplant list or not, and what's the likelihood for recurrence for the primary disease after the transplant. Because remember, this primary disease, especially if it is immune-mediated, it may happen again on that patient. And you can see the patient can be at risk again to have organ failure for that transplant, and then he has to go again to the waiting list for another kidney. Also, we get the explant kidney. Now, we don't get it always all the time, but you can get it. So the patient end up in the transplant list. He was lucky enough that he got a suitable organ. They may or may not take the diseased kidney. Sometimes they leave the native kidney and they will just put the transplant, the allograft kidney, and sometimes they will take that kidney out. So the role of pathologist, the transplant pathologist in this situation is when you get the explant kidney is to examine that kidney grossly and under the microscopic examination. First, to confirm the primary disease, right? Like this is what they expect. Second, sometimes to see if you have unexpected findings. So, for example, this case, you can see this is one of the kidneys, and you can see the gross description that show you multiple cysts. And this is from the name, if you remember, multiple cysts. This is polycystic kidney disease. This is a common for patients. They're going to end up having end-stage kidney disease, and unfortunately, they have to get another kidney. What I mean by unexpected finding, so the patient, in order for the patient to go to the transplant list, it's a very long process. He has to do multiple clinic evaluation. He has to do immunology tests, serology tests, imaging tests to be excluded. Because just imagine if this patient have incidental cancer, which happening, the patient unfortunately will be out from that list. But sometimes these incidental findings cannot be obvious through the imaging study, and the patient will go on the transplant and everything gonna work out. And then when we examine that explant, we can see cancer, which can happen. This is a case not for explant kidney, but this is for nephrectomy to show you how renal cell carcinoma look like. This is some of the normal kidney, and this is a circumscribed mass with area of hemorrhage and necrosis. It turned to be renal cell carcinoma. So sometimes we can have unexpected findings, and you call the surgeon, oh, this patient has renal cell carcinoma in his primary kidney. I mean, they already transplanted that patient, but they have to be more careful and follow up this patient in a different way. Okay, one of the common and it's more stressful biopsy, I have to say, we get it as a transplant pathologist, is the donor kidney. So what I mean by that, this is a very time-sensitive thing, because when you have a donor and the donor is available with all the organs, the organ cannot stay out of life forever. So they have their certain time frame that they can have before you can get it to the body. So usually when you get the donor, you are in rush. They have to make sure it's a good donor organ, it's a good organ, then okay, we need to transplant it to that patient as quickly as possible. For example, the kidney can survive. Kidney is one of the organs that can survive up to 24 hours. But talking about heart, barely can be 4 to 6 hours. So you can see what is the stress the surgeon is, the nurses, the team, everybody's under stress. This organ has to go to the proper recipient. And sometimes, in general, these donor is not mean always it has to be in the same state. So you may have a donor in certain place, and the recipient is in a different state. Remember, I told you this federal organization, that UNOS, they are the one who organize these organs. So sometimes the donor will be in a different state than the recipient. So they quickly have to evaluate this, the kidney, for example. Is it good? Then let's send it to the proper recipient with a proper location, and let's everything be done, and everyone is going to be happy. So the question that comes, okay, why they need us as a pathologist for donor kidney? If you recall from the first slides, I show you that there is some variation, and there's the gap between how many organs we have and the people who are needing this organ. So there is a gap between the waiting list and the real organ. This was in the past even bigger and bigger gap. So what happened initially, they have restricted the criteria for the donor, like the donor has to be young, he has not to have certain medical condition to accept this diseased person as a donor. Because of this gap, they say, okay, let's change that a little bit. So they have extended donor criteria. They extend their criteria a little bit in order to get more donor. So we hopefully get decreasing this gap list. For example, for kidney, now they accept a patient who is older than 60-year-old, we'll take it as a donor. Patient with certain medical problem like hypertension, we may accept that donor. So there is extended donor criteria. But what is this will add for a pathologist is, yes, they accept the patient who has a hypertension or who is like elder, for example, but they want to make sure that kidney is good before they put it on that body. So they will call you. They will. This is the common thing you call for a frozen section for a rush biopsy. And unfortunately, it can be in the middle of the night, can be 3 o'clock in the morning. You cannot predict, because basically you cannot predict when that person died. They will call you and they say, oh, hey, doctor, can you come and evaluate this kidney? Is it good? Is it suitable? So we can proceed and put it in that recipient. So we came in to evaluate this donor kidney biopsies. So the main 2 questions they want us to answer. Is this kidney suitable for the organ transplant? Shall we proceed with that? Number 2, do we have any pre-existing condition for that kidney? And we can use it as a baseline disease for that kidney for the future follow-up for that transplant process, because they're going to rebiopsy again the kidney when it is on the recipient to evaluate it. So they want to see, okay, how much, if we say there is a little bit of interstitial fibrosis, for example, like, or there's some chronic injury in that kidney from the beginning. So if I see chronic injury after maybe 2 years after a transplant, I will have put in my mind, like, okay, remember, this kidney from the beginning has some chronic injury. It's not all happening after the transplant. So just to give you the baseline disease process in this kidney. Because as we say, most of the time you're going to get called for these donor biopsy to evaluate, they will have under the extended donor criteria. So this donor is not the perfect donor. It's usually, if it's a perfect donor, they will not call for the biopsy. But I would say almost 50% of the organs, we get called for these to evaluate the kidney. And believe me or not, we can say almost 20% of the discarded organ, it's because of the biopsy interpretation by the pathologist. So you can see how much stress can be on the pathologist, because your call, how this kidney is working or not, gonna affect the clinician decision to proceed with that kidney or not. So your call can let the patient go and take this good kidney, or stop, this kidney is not good, you cannot take it, and you have to go again in the waiting list and wait for another organ. So this is just to have an idea what's mean by donor kidney and what is stress we face, especially in the kidney and liver, we'll talk later on. So the donor kidney biopsy, we receive either core biopsy or it can be wedge biopsy. This is in the frozen section. We freeze it and we evaluate. So what we evaluate is adequate biopsy. Like we need at least 20-25 glomeruli to see, because you need this specimen to be representative for what this kidney is. So we need at least 20 to 25. And then we have to look for glomerulosclerosis. Like this picture I'm showing to you is totally sclerotic glomeruli. So we really count how many sclerotic glomeruli over the total glomeruli. Usually, if it is more than 20% sclerotic glomeruli, this is a question mark kidney. If that's the only thing we say, they may proceed for this kidney, but it's not like the perfect kidney that the patient will have. But that also can be clinician decision, pathologist decision, and the overall condition for the recipient and the donor. Also, we see, like here, this is another sclerotic glomeruli, but this is focally segmented glomerulosclerosis. So this may be the patient has a medical kidney that is hidden. He did not been diagnosed before. Also, we evaluate for tubular atrophy and interstitial fibrosis. These are features for chronic injury. We're going to see how chronic this kidney is damaged. So you will see atrophy, like the picture I'm showing you, very small tubules, and then you don't see much interstitium because it's fibrotic. Like this one is better even. You can see this is some of the normal tubules, and here it's absent because basically you have atrophy and interstitial fibrosis. You have a chronic injury. Also, we evaluate the vessel. Remember, one of the patients can be a hypertensive patient. In hypertension, their blood vessels can be affected. Like this one I'm showing to you here, you can see how it is thickening. It's a sclerotic vessels. And based on that, again, the clinician has to decide, should they take the kidney or not? And of course, if we have unexpected finding, believe it or not, sometimes we have very rare unexpected amyloidosis in that kidney. The problem sometimes what happens is you cannot evaluate everything in the spot. So you may say, okay, this kidney looks good, take the kidney. And after, the next day you get a nice permanent section for that, you discover some unexpected finding, amyloidosis or lymphoma, CLL, small lymphocytic lymphoma. This is can happen, although it's not common, but it can happen. This is also something can be challenging because if you find unexpected important finding, I'm talking about lymphoma in the donor, then all patients and all institutions who took some of these organs, they have to be notified, like, hey, the donor that you have, whether the kidney, whether the heart, whether the lung, this patient, this donor has CLL, and hence they start to work up with that recipient. So sometimes can be in that stress, like, oh, okay, I did not expect to see that. Then you have to call and do your emergency call for everybody, like, hey, this donor unfortunately has a problem, has a cancer that did not find immediately. So it can happen. It's not common, but it can happen. It is rare, but it's there, unfortunately, for that. Then we can get also for the transplant, our main thing, allograft kidney biopsy. So what they want from the allograft one is, so what we mean by allograft, that means this is the kidney, this is not the native kidney. This is the kidney where we were transplanted to that recipient. What the idea is came with that, they found like, okay, the main reason for the organ to be failed in that recipient is rejection. You can sometimes tell that this is a rejection from the kidney function test for the patient, but unfortunately, the main way to do it is through the biopsy. And here again, the role of pathologists came. They depend on us to see how bad is this kidney? Is this kidney rejection? If there's a rejection or not rejection. So rejection, it's an immune-mediated process, right? So we have what we call it cellular rejection, and we have antibody-mediated rejection. Cellular, that means the lymphocyte is attacking that tissue because they recognize it as a foreign body. Or we have immune-mediated, antibody-mediated process. We detect the antibody-mediated through also we have our own feature to see that this is related to the immune-mediated, but also we use what we call it C4D immunostain. This is one of the stain that's related to the immune complex that was in the process for the antibody-mediated rejection. I'm not going to go that detail on this one, but this helps us to know that there is a probability for antibody rejection. I put a plus minus for C4D because it's depending on the institution. Some place like the immunofluorescence one and some places like just immunostain. Immunostain is a special technique. We use it in the lab. It doesn't have to have a different biopsy, the same tissue and the paraffin block tissue. We use a special stain to highlight C4D. Immunofluorescence or immunostain, they both have some advantage and disadvantage. That's why certain institutions like to use the immunofluorescence and some institutions like the immunostain. So they give you the biopsy to see if there's a rejection or not, but also we receive it as what we call protocol biopsies. So what I mean by protocol biopsy for allograft kidney, when they transplant the patient, especially in the first year, they want to make sure that this kidney is functioning properly. So it depends again from institution to another how they put the protocol. What I mean a protocol, like they set a certain date, like after a month from the transplant, the patient has to come and biopsy the kidney, whether if the patient is symptomatic or not, after 3 months, after a year. And after that, if the patient becomes symptomatic, or like yearly after the transplant. This from institution to institution, they have to put their own protocol criteria, like when is going to be the best time to biopsy. The reason behind that, so they found sometimes that there are certain organs like kidney get failed and they have to take it from the recipient, even the patient was not that much symptomatic from the beginning. They did not have abnormal kidney function test. Because of that, they say it's better to biopsy these patients, especially in the first few years of their transplant, to make sure that that kidney is working properly. There is no problem. Because you can see some patients, they have normal kidney function test and they have a bad rejection happening in the kidney. Don't ask me how. Sometimes this is how the body reacts. The patient are in immunosuppression, so the way the body reacts to it is different in another way or another. And then if this patient left untreated with any immunosuppression, this say end up sometimes with organ failure. That's why they have a protocol biopsy. What they do, they bring the patient, if the patient is in the protocol or if the patient is symptomatic, in the morning in the hospital, biopsy the patient, and they expecting the pathologist to give the result in the same day. So by 3 or 4 o'clock at the most, you have to give the clinician and the patient the answer. Do you see rejection or not? Is it a mild rejection? Is it a moderate rejection? What you see. Based on yours, it's going to be treatment, either going to be modification of the treatment, or at the worst, the patient will be admitted in the hospital. Because the patient will stay all that time waiting for the pathologist result. And sometimes, like the clinician will come even and sit with you, like they are so curious to see what's going on with this patient. So I told you it's mild, moderate, whatever these criteria. So based on what? We have a standardized, or we call it Banff criteria. So if you hear this in your search in Google or anything, this is basically a standardized criteria for cellular and antibody rejection. Just if anybody look to that kidney biopsy, if I say it's Banff criteria 1A or it is 2A or 3 or whatever, they know what I mean. They know it is mild or it's moderate or whatever, just to make it standardized for everywhere and every place. So this picture I'm showing you, just you don't, it's too much details, but you have an idea what the rejection is. Like here, cellular rejection, when you have lymphocytes attacking the tissue. Like here, this is the tubules, and you have the lymphocytes attacking these tissue. This is rejection. This is a capillary and a vessel, and we have lymphocytes attacking the vessels. Actually, when we see this, this is one of the bad rejection. This patient needs way more treatment than the normal one. Here to show you glomeruli, and there is a lymphocytes attacking these glomeruli. So we really look very careful in this rejection. You go in the high power, the microscope, you have your time, because it's important to detect this rejection or not. But of course, it's allograft kidney biopsy. It's not always just rejection. The patient may have elevated function test because of infection, like common on the kidney polyoma virus. These patients are under immunosuppression, so they are at risk to get sporadic, like opportunistic infection, right? Some sporadic viral, opportunistic viral infection like CMV, herpes, polyoma virus. They can get fungal infection, something unexpected. or they have lymphoma. They can have lymphoproliferative disorder related to the transplant. We call post-transplant lymphoproliferative disorders. In addition to that, the patient, unfortunately, sometimes with all these modalities, he ends up having failed of this graft, and we can receive it in the transplant field to see what's happening, why this patient, this organ was failed. This is just to give you an idea. You're not going to go through it. Just this is how the band for criteria for antibody-mediated rejection, like this one, this table. So you can see the standardized way in signing out these. And this is cellular rejection criteria too. So if I call to anybody, oh, this patient has type 2B, they know what I mean. That means it's a severe one. This patient has to be treated. Another organ we receive is the heart transplant. So you have it, the heart transplant is the same thing. The idea for the heart, so for the explant heart, when they retaken that heart, we don't get it as a transplant pathologist. The explant heart usually go to the cardiothoracic fellowship people. So there's a cardiac pathology fellowship. They usually get the explant heart and see what's going on, why this patient has end-stage heart disease. For us, usually we get endomyocardial biopsy, and this endomyocardial biopsy for the allograft heart to see how this heart is functioning. Is there any rejection for that heart or no? So it's still the gold standard to detect for rejection for heart specifically. And the same thing, the patient will have a protocol, enter the protocol with certain time, with certain frequency for biopsying that heart to see, is this heart rejecting or not? Shall we change the treatment, or this patient is doing good? So they can go through the biopsy, and the other they go through the transjugular. Sometimes they go through the groin area if it is really difficult to see the transjugular vein. They go through the right heart and then biopsy of the heart, and then the lab will receive it. Usually we like 3 to 5 biopsies per patient, and they biopsy this and we put it directly in formalin. Now, if that lab wanted to detect antibody rejection, so we can put some tissue for immunofluorescence C4D. If the lab is believing in immunostain, not the immunofluorescence, then it all will go in the paraffin block, and we handle it in the same way we handle the main. It came to the pathologist, the same thing. That protocol, that's his heart biopsy, it's a rush biopsy. The patients come in the morning in the hospital. By the end of the day, he is still in the hospital waiting the pathologist to say, there is a rejection, there is not, mild, moderate rejection, or whatever you see, cellular rejection, antibody rejection. So they're waiting on you. So it's becoming, you are in that dynamic circle. You get kidney biopsy and then you get the heart biopsy at the same time, and you have to. This is pictures to show you. This is what we evaluate for adequacy for this allograft biopsy. Usually we need, as we say, 3 to 5 biopsy. Think about it. I mean, sometimes rejection can be patchy. So we try to increase the number of biopsy in order to increase the likelihood of detection the rejection. It can be cellular rejection. You can see that dense lymphocytes attacking the heart here and here with all of much. And we have, again, PANF criteria as a standardized way for cellular rejection and antibody rejection of the heart. This is here to show you this normal heart without much lymphocytes. This is just endothelial cells, and this is how bad is the rejection can be. Also, we can detect infection, CMV, opportunistic fungal infection, anything, because the patient is immunocompromised, and again, for post-transplant lymphoproliferative disorder also can be seen in the heart. This is another picture to show you the antibody, and this is antibody-mediated rejection, and this is what I want you to know. This is if we have to decide to do C4D through immunofluorescence, very bright deposition. We see it mainly in the capillaries area, or we do immunostains in the lab with this brown coloring. So you can see whenever I see this strong positivity, that means this patient may have antibody rejection. So this is what we do in the heart, mainly for the allograft. Also, we do it for small bowel. So that transplant, they transplant the patient most of the time. If these patients are Hirschsprung disease or Crohn's disease, like they need this new bowel, or patient who's for certain problem, he's been in TPN, total parenteral nutrition, for a longer time. They can't be that long because TPN can affect, for example, the liver. So the patient be forever in TPN. Sometimes they end the patient for small bowel transplant. As a transplant pathologist, what I receive the small bowel biopsy to evaluate for rejection. How good is this small bowel? Is it rejecting? Like the arrow I'm showing you here, apoptosis on these crypts, and this is a feature for rejection. So it's my job, my responsibility to call the clinician and say, yeah, this is rejection, this is not. And again, we have a criteria to say it is a mild rejection or it's a moderate rejection, because based on that, they can alter their management to the patient. The same thing in the biopsy will tell infection, and we have to say if there's PTLD or not, post-transplant lymphoproliferative disorder. Another organ we received to the transplant fellowship, it's the pancreas. The same idea. Sometimes the pancreas, they transplant it plus with the kidney. Because think about it, why it's going to be the main reason to transplant the pancreas? It's usually if the patient is diabetic. So patient with diabetes, most of the time they're going to have a kidney disease related to that diabetes. So most of the time they have end-stage kidney disease because of the diabetes. In addition, the pancreas is not working. So they transplant both organs at the same time. Unfortunately, I have to say pancreas is one of these sensitive organs. The success rate is not that high in the pancreas, but they try their best with this immunomodulation to help that organ be function as long as possible. So they cannot really monitor the pancreas much compared, like the kidney, we have kidney function test. Pancreas, they try to monitor it through the enzyme in the clinician, like the amylase enzyme, all these pancreatic enzymes to see, but at certain point, sometimes they have to biopsy the pancreas to say, okay, I feel there is something going on. The amylase is high. Let's check how the pancreas is doing. They bring it to us. Sometimes you can see also if they have a co-transplant, pancreas and kidney, sometimes they will go after the kidney, not the pancreas. So if they say the kidney is not working good, then most of the time the pancreas is not working good. So let's increase the immunosuppression. But sometimes they really have to biopsy the pancreas. And again, the same thing, we see the rejection, how much lymphocytes attacking the acini, attacking the ducts, and see how much rejection we have. And infection, and if there is a lymphoma related to that organ. I will end my presentation with another main organ, more challenging organ, which is the liver. So I told you in the transplant fellowship, you also going to see a flavor for the medical liver kidney disease. So this is what we do in transplant pathology fellowship. Like I'm talking about one also that I did, you will see medical liver and medical kidney disease in your fellowship. So talking about the liver, it's the same thing. You're going to get donor, you're going to get the native liver, and you're going to get the allograft liver. So we'll talk about the donor liver. It's the same idea. They will call you to say how this liver is looking. Is the liver looking good? So shall we go ahead and transplant that? Or the liver is like, maybe it's at the borderline, or what's going on. So you want to see assess the likelihood of adequate allograft function. And also you want to say, document the baseline allograft disease. Like if there is a little bit of fibrosis in that liver before the transplant. So this is the clinician has to put in their mind. And evaluate degree of a preservation injury. So what I mean by that, so remember these organs, they are in the donor. They take them out and they put them in preservative solution because you're not transplant that liver immediately. Like sometimes you stay for a few hours, till the pathologist came to call, then you find the recipient and you prepare the recipient for the surgery. So it can sometimes have a few hours. So they put the liver in that preservation solution just to cool it down. So we try to increase the survival of the cells in that liver. So you want to see if that liver can tolerate all of this stress condition on it. For example, sometimes you get the liver that is fatty liver. It's a very bad steatosis in the liver. Steatosis means we have a fat accumulation in the hepatocytes. So if I have a liver that is 50%, 60% steatosis, that means this liver is unlikely to survive much after we transplant it to the recipient. Because that's a stress event, you cool that liver, and then all of a sudden, then you're going to put it in the recipient. The recipient will have a blood perfusion to that area. So you can see sometimes the liver cannot handle that much stress. I mean, sometimes it does. If it's the only problem, just the steatosis, they may still accept that liver. But this is all, it depends on the clinician, on the patient recipient, and the patient, the donor. And you put all these data together and see, shall we take this liver or not? Diagnose mass lesion. Again, you can sometimes see unexpected finding. And then you have to do these liver. So here to show you what they call you for the middle of the night. Again, this is a common to be called. It's either to midnight or it's like 2 or 3 o'clock in the morning to see how this liver is doing. So it's the same thing. We see adequacy. If this is like this biopsy really represents the liver. And then we will evaluate if there is a steatosis. That's number one. How much fat, like this picture, the liver has. And then we evaluate for hepatocytes necrosis. Like these two slides I'm showing you at the upper side, you can see how much necrosis. Usually if it is 10, 20% necrosis, up to 30 sometimes, they may accept that liver. But if it is more than 50%, that means this liver is not doing good. So they will not accept it and it will be discarded, unfortunately. So that's why you really have to be careful. You really to have much experience in order to be accurately evaluating these organs when you receive it in the transplant field. We also see if there is any other inflammation like this dense blue, that's all inflammation. If there is a fibrosis like this one, almost forming nodule. So this is almost cirrhotic liver. So this liver is not good really for transplant. Because what also help, you need to keep it in mind. Remember, it's the same thing that we have that gap between the number of organ available and that people are on waiting list. There is also extended criteria for liver for all the organs. So for example, in the past, they were like, for a patient who is hepatitis C positive, shall we, that donor, give it to the recipient that is hepatitis C negative or not? In the past, this was like, no, it's like a red line, you cannot do it. Nowadays, with all this medicine evolving and the new technology with the new medication for hepatitis C and the cure rate for hepatitis C positive, they start to accept some hepatitis C positive donor to hepatitis C negative donor, recipient. They will give that liver, they give the patient hepatitis C treatment, and the patient will not have hepatitis C in his body. At the same time, he got that liver. That's why they will need you to see hepatitis C will affect that liver. So they will ask you as the pathologist, how this liver look like? Is it badly affected by the hepatitis C or not? And this is your job to say, how does it look? Is it much fibrosis, much injured? So we should not take this liver. Or it's still okay, you can take it, give the patient the medication, and he should be fine. We also receive in the transplant pathology department the explant liver, the liver that was taken from the recipient, the native one, and we can examine that liver. So for example, this one, we can see if there is hepatocellular carcinoma. This is one of the reasons sometimes the patients are in the waiting list for transplant because they have cancer. Or it's advanced liver cirrhosis like this one with multiple nodules, or this one is smaller, the micronodular liver cirrhosis. And we examine this and see why this patient has end-stage liver disease, secondary to what the cirrhosis. It can be secondary to infection, can be secondary to biliary disease, or metabolic disorder. Common is steatohepatitis, fatty liver disease of the liver. It's a very common entity, either because of alcohol or because of metabolic syndrome, like patient diabetics or obesity, that cause the patient to have end-stage liver disease. So it's our job to examine these liver and see what's exactly going on. Or if you have unexpected finding, the same thing. They think the patient just have cirrhosis, Then you slice it down and you cut it and you see it and you find there is an incidental cancer. So this is all can happen in the transplant era. And again, you have to do your own call and communication with the clinician. That's why in this specialty, really, it's always important to have a good communication and a good connection with the clinician, because you're always going to call the clinician for a reason or another. Another biopsy is the allograft liver biopsy. So it's the same idea. The patient, after the transplant, he can go on certain protocol biopsy for certain time to evaluate the liver, how the liver is functioning, and to evaluate if there is any rejection or recurrent for that disease, the primary disease for that patient. So this is your duty to evaluate that liver. That's why, as a transplant pathologist, when you evaluate allograft biopsy, it's very important to know the clinical setting for the patient at the time of the biopsy. See how the patient is doing at that time. Is the patient really sick? So you can see, okay, that explains what I'm seeing: rejection, attacking of lymphocytes to the bile duct, to the vessel. This is all feature for rejection. Like here, this is one of the bile duct been attacked by lymphocytes or not. And then you call the clinician, like, okay, what's the status for your patient? Sorry, how the patient is doing. Because for me, for example, this patient is really sick. You always have communication and call between you and the clinician. Recurrent of the disease. It's your problems to see. This is the core liver biopsy because this patient rejecting, or this is a recurrent. For example, this biopsy for a patient who is hepatitis C. This is what I'm showing here. It's dense inflammation, but this is because of recurrent hepatitis C, not rejection. So you can see how critical your call is, because if you say this is a rejection, they're going to give immunosuppression. But if you say this is a rejection, this is a recurrent hepatitis C, if they give immunosuppression, you're going to worsen the patient condition. So it's important. That's why you need a really fellowship trained to be able to say this stuff. For example, this is next. This is dense lymphocytes and dense inflammation too, but I'm telling you, this is rejection. So, and sometimes can be dense like this lymphocytes. There are different criteria we use to differentiate, but sometimes we reach to the point I have to call the clinician and see how the patient is doing in order to help clinical pathologic correlation and see if it's really rejecting or it is not. Also infection, EBV infection, CMV, that also can happen in the liver. Any opportunistic infection can happen in any immunocompromised patient. And remember, your patient, the transplanted patient, they are immunocompromised because of the immunosuppressive medication that they are on. So they are prone to have infection too. And last but the least, they may have also lymphoproliferative disorder secondary to the transplant. So this is a little bit overview for, in general, what we do in the transplant. We have multiple organs. You have to see all these organs, you evaluate all the organs, and you have to correlate sometimes what's the medical problem before the transplant and after the transplant, what you see, because sometimes what you see is not rejection. It can be recurrence of the medical problem. That's the main thing, what we do in the transplant field. And it's a little bit, it's a challenging, but it's interesting all the time because you have always put the patient. So yes, we see slide, but behind this slide, there's a patient. And you have to put what's the clinical symptom for this patient, what the clinical setting for that patient before you came up with your diagnosis. That's the main thing, and I hope you enjoy and you like the transplant pathology. And I'm open for any question or anything you have.
Thank you so much, Dr. Yadak. You have definitely piqued my interest. It was a very, very interesting presentation. At this time, we'll take any questions. You can feel free to unmute your mic, or if you'd like to type them in the chat, Dr. Yadak will be more than willing to answer them for you.
Hi, good day.
Hi.
Yes, Dr. Yadak, very insightful presentation. Thank you for taking the time. Also, I wanted to know when we do any sort of topic pertaining to transplantation in med school, they always bring up xenografts. Is that like something that you would have encountered at any point? And is it like a common thing or is it very beneficial or something?
So it's interesting things because yes, we do have it, but I have to say in my practice in real life, I have not faced it much. It's mainly what we see, it's like these ortho transplant. It's mainly from human to human. That's what we face mainly. But, they have so many research and they have so many experiments that's happened regarding this xenograft. But yeah, for me personally, I have not seen it much.
Okay, second question. With respect to the small bowel transplantation, I remember you said that for the pancreas transplantation, it's not usually as successful as we would like it to be. Is that also the same for small bowel transplantation, especially in the context of Crohn's disease?
Yeah, that's a good question. So in general, yes, I have to say, unfortunately, small bowel and the pancreas, this is something new in the era of the transplant world. So the success rate is not high as comparing to the common organs like kidney and liver. They try to do that. I don't think it's especially small bowel, it's because of the recurrence of the disease, because they give the patient, especially like if they have the patient who has a Crohn's disease, they give them very high dose of immunosuppression. So the recurrence of the disease is unlikely that much to happen. However, small bowel is also kind of sensitive organ, so the success rate is not high. But this is something new in the era of the transplant. So maybe after a few years, people are really still researching on these organs and see how they can improve the survival rate for this. So hopefully within a few years, we get better and better success rate for these. But it's improving. So if you go to your PMC, you can see there's a very big transplant team just dedicated for the small bowel. So they are in improving the success rate. So hopefully, it's something new. So whatever you have something new, you have to keep in mind that you may have some challenges to get it success, but at some point it will be.
Okay, thank you. And probably my last question. If I was to pursue this field, would I have to memorize these criteria, such as the BANFF criteria, like by heart? Because it seems kind of complicated.
Yeah, I agree with you. It's complicated, but believe me or not, you're not going to memorize it. But by the time, so you see almost 1,000 of biopsy per year regarding this stuff. So by the time you finish your year, you're not memorizing them all, but at least you start to know, okay, if I see this biopsy, I mean, you still have to have your criteria next to you and to double check, like, oh, I think I'm in the mild or moderate, but you reach to the certain point that your eyes get used to certain look for this inflammation, that this is most likely going to be the moderate rejection. You can go and check your PANF criteria, and you can see, you will be surprised that you're going to be correct most of the time. So you're not supposed to memorize it, but by the time you practice more and more, your eye going to get used to them. So yeah, don't just stress yourself that you have to memorize them now. No.
Okay, that gives me some hope. Thank you again for the great presentation.
Thanks.
Are there any other questions? Please feel free to unmute or type in the chat. Yeah, while we're waiting on persons, if they have any more questions, one question for you, Dr. Yadak. Is there a specific, let's say, misconception or stereotype that you think is associated with the subspecialty of transplant pathology that you think that we should be more cognizant of or more aware of?
So you're talking about misconception regarding the specialty or what's the specimen we see?
Yes, any misconception that you think you've encountered in your practice that you think we should be more cognizant of?
I really that's hard because I'm not thinking for anything right now, and I'm not sure what really can be stereotype thinking. But maybe if people think if you are in transplant pathology, you're gonna be, you know everything about the HLA immunophenotyping, for example. This is not as a transplant pathology. I mean, you can have exposure on the HLA immunophenotype, and you go to the HLA lab, but the HLA lab is different from the transplant pathology. So the transplant pathology, we don't see much for these HLA. It's the HLA people. There are different people who look to these things. The other thing, we are transplant pathology, but remember, as we said before, we are an AP subspecialty. So really, I don't see a stem transplant in my era. So usually if you have a bone marrow transplant and all this will go to the hematopathology. So this is a different specialty with a different even requirement that they have for this. So hematopathologist people, they look to the bone marrow transplant. Transplant pathologists, they don't look for these. This is considered CP part. So that's the main thing I'm thinking now, but that's the only thing that came to my mind now.
Thank you very much. We will just wait about maybe 5 more seconds if anybody has any other questions. Okay, well, you can feel free to either email us if you have any questions that you thought of after the fact, and we'll get it across to Dr. Yadak. As we're about to close the session, thank you so much again, Dr. Yadak. We just have a little presentation here where some of your attendees were quite, as you can see, pleased and very happy with your presentation. They found it very enlightening, interesting, thought-provoking, engaging, amazing, very insightful, inspirational, and quite a different. And you have definitely piqued my interest as well.
Yeah, thank you. Thank you. I hope you guys, I'm glad that you like it, because it's a little bit different specialty than the usual thing. You know, it's not like the traditional specialty that everybody faces. It's a little bit unique.
Yes.
And like you have really to like it, but you're going to like it. If you're going to proceed it, you're going to like it. Sooner or later, you're going to love what you're doing.
Yes. Thank you so much. So now I'll deliver the vote of thanks, and I do hope that everyone had a wonderful learning experience. As we express our gratitude, we must never forget that the highest appreciation is not to utter words, but to live by them. John F. Kennedy. Firstly, I'd like to thank our featured speaker, Dr. Nour Yadak, who, despite her busy schedule, graced us this evening with an amazing and enlightening presentation where we were all extremely grateful to learn about transplant pathology. While we are most happy that you were able to give us an insight into transplant pathologies, we are hopeful that your audience was able to take pertinent notes and was reminded, if not educated, on the importance of not only the subspecialty of transplant pathology, but pathology itself. We would also like to express our gratitude to Dr. Alfredo Walker, our Executive Director, for joining us with his presence this evening. We appreciate his endless support and thank him for playing a key role in supporting us throughout our journey thus far. Last but not least, ladies and gentlemen, I would also like to thank you all for accompanying us tonight and making our event a success. We look forward to your continued support. To all our UWI students and staff across the 3 campuses at the University of Ottawa, Eastern Ontario Regional Laboratory Association, and especially to our specially invited guests, thank you, thank you, thank you. Our next CPALMSI session will be on ophthalmic pathology featuring Dr. James Farmer on April the 13th. Ladies and gentlemen, this marks the end of our session this evening. Thank you all for joining us for our 22nd installment of CPALMSI, and we hope to see you at future events. Good evening all.